Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We have the great privilege and pleasure in hosting Dr. Shalou Powell, who is a co-editor for Mastering Myopia newsletter, researcher of the Myopia in Practice study, past chair of the AOA CLCS, and founder of the Canadian Contact Lens Academy. He's a CE advisor for the OAO, AOE, and Latin Americas, global ambassador for GLOW and BCLA, and co-founder of the Staple Program. She volunteers locally and internationally while running a group practice in Toronto. She is also specialized in specialty contact lenses, myopia management, dry eye disease, and aesthetics. She was awarded the LCS Achievement Award for providing education to the industry and the Legends Award by the AOA. So with it, let's give a nice virtual round of applause and warm OEC welcome to Dr. Shalou Powell. Please take it away.
Thank you so much, Joe. Greg, before I get started, did you have something you wanted to say?
Yeah, there was a little bit of a comment that you and I were discussing before coming on live here. And yeah, thanks for giving me the opportunity. And I just wanted to kind of, point out that in the late 1990s to 2000, I had the privilege to go to Singapore, I don't know, 8-9 times, go over there, kind of teach the ocular disease, how to interpret it, visual fields, OCTs, retina disease, so on and so forth. But while I was there, myopia control was big, and it's still big. This year, I headed to the European Academy of Optometry and Optics, and again, the privilege to be able to bring some oc disease to that meeting. But obviously, one of the main focuses was myopia management. So definitely, it seems to kind of be a global crisis here. Maybe that's what you'll point out tonight, but I appreciate you here tonight bringing myopia management to the OEC community. So if any of that sounds accurate or inaccurate, please tell it, please feed into that for us.
Absolutely. No, you're spot on. And I just want to say thank you to both Joe and you for inviting me to do this. I'm going to tell you a little bit about my practice and sort of how I got started. Here are my disclosures. And I think one of the things to really understand my practice and understand sort of me is to understand my why and why I do what I do. I didn't realize how important my why was to me until I started reflecting back. So this whole concept comes from Simon Sinek, and we were maybe at an Alcon meeting a couple of decades ago and learned about this whole concept of what's your purpose, what's your reason, why do you do what you do? We know what we do, that's eye exams, and we help people, and we do that through all the care that we give. But why do we do it? And what I started to realize with all the decisions that I made in my life, from choosing the optometry school, choosing my undergrad, choosing my residency, choosing the place to work, moving, expanding, all of these changes that I've made and the decisions I've made all stem from this root understanding of what my why is. And my why is very simple. It's about being happy. It's about me being happy. It's about my patients being happy, my staff being happy, and just sort of spreading that joy as much as I possibly can. And, when I think about my office, where we're located, we're in downtown Toronto, in a posh area with, it's been such a roller coaster of a ride over the last 15 years that I started the practice. I took it over from another lady who was there only 2 days a week, and we slowly built it. I brought on my first associate. Her and I were sitting and just chatting, and she's like, I really want a place to practice. And I started telling her about the goals that I had. I missed practicing the way I did in school and during my residency, and having access to everything, all the equipment. When I need something, it's like, oh, just go down the hall and there's the imaging clinic, there's this clinic, there's that. And so I was like, I'd love to practice that way where I had everything. And she looked at me, she goes, well, why don't we build it? I'm like, let's build it. So 14 years ago, that's what we started, and we slowly gathered all the players. We have 6 doctors now in the office, 12 staff, and we have every subspecialty within optometry under one roof. And I love what I do. I love going to work every day because I love the people that's there. And how I've chosen my team, and I'll share these photos here with you, is people that like to have fun, people that smile and want to take care of patients, and we have a lot of fun together. So a lot of what's happened with my journey with myopia management, I'm going to share, but I think you understanding a little bit about me before we dive in will it'll come throughout the rest of the presentation. So why should we offer myopia management? I loved, Greg, that you did that polling question in the beginning, because half of you are dabbling in it, half of you may not be. I hope throughout this presentation, you pick up something either that inspires you to maybe try something new, but please throughout, if there's any questions, stop and let's go through them. We have these polling questions throughout that we can use and take advantage of those to answer questions too. This is really for you to hopefully gain something out of it. I've got tons of slides. We don't have to go through them. I can go through them all, but really I want you to feel free to jump in at any point. When I think about myopia management, I want to just kind of give you some overview, like let's think of the basics, and you may have heard this, but by the year 2050, half of the world's population is going to be myopic. The higher the myopia, the greater the risk of future ocular complications. We can't actually stop the progression of myopia. The eye is going to continue to grow no matter what we do. That's a really, really important thing to remember with respect to our patients and our parents really understanding that piece. The level of myopia will continue to increase no matter what we do. We can slow down the rate of refractive error progression by 50 to 60, 70%. And we're going to dive into these numbers a little bit more to show you what's actually doing that. We can slow the rate of axial length growth up to 60%. And if we can reduce myopia by 1 diopter, we can decrease the risk of myopic maculopathy by 40%. And this was a study that was done by Mark Bullimore. And this really, really hits home to why are we doing what we're doing? If we can prevent 1 diopter of progression of myopia, that has a huge impact on the future life of our patients. For me, one of the things that I once said is everything that I've learned over the last, 13, 14 years of doing myopia management, I can't unsee it. I can't now just close an eye to what we know about the impact that we can actually have, how we can change the lives of our patients, the difference we can make, what the global impact can be, the financial global impact that myopia brings. There is so much responsibility that optometry can own, and we can take and have a role in actually making a difference. So for me to see a myope in my chair and not think about a myopia management strategy, I just don't know how to do that anymore. What was really interesting is the World Society of Pediatric Ophthalmology and Strabismus actually came out in endorsing myopia management. And guys, if you've worked with ophthalmology, like I remember when I moved back to Toronto from all my schooling in the US, and I was doing Ortho K. I was one of the few in Toronto doing Ortho K. Ophthalmology was like, this is garbage. It's not safe. Don't ever do this, telling all our patients not to do this. And so to have it such an early phase in myopia management, to have this endorsement from ophthalmology, it's huge. And, this excerpt that I took from this document, the benefits outweigh the risks, and there's sufficient evidence towards adoption of myopia prevention and control measures in clinical practice in children with progressive myopia. This is huge. This for me was such a big deal that, okay, we've got the stamp of approval. And not so much the stamp of approval, but we don't have this force that's going to be fighting us. I remember when I started my dry eye practice, and ophthalmologists in Toronto, they were like, oh gosh, dry eyes is a condition that's just been created by optometry to make money, right? Like crazy, but that's what we were dealing with. So this is so awesome to have their endorsement and not have to have a fight with them. So the impact of myopia management, well, let's think about our kids. Let's think about their quality of life. There's been so many speakers over the last, years that I've listened to, myopes themselves, that have said how socially being more myopic has had an impact on them. And that's a really important to think about how it impacts our kids, how it impacts their perception of the world, how people perceive them, how it affects their self-esteem. And, we don't really think about it as much as adults, but it does have an impact. Think about them wanting to have LASIK when they're older, better quality of life. Think about the economic burden. This all has an impact on them. One of the interesting things that someone just said at the Academy meeting was, think about what we're actually doing and who we're helping right now. And when they become 60 and 70, and we have prevented them from having these conditions of glaucoma, myopic maculopathy, and retinal issues, we are actually never going to see those patients because we're not going to be still practicing when they're 70 and 80 and right at that age. So it's crazy to be thinking that we're having this impact on children's lives that's going to be happening in the future. And we're actually never going to see the full effect of how we've impacted people. But we do have a great impact. With respect to parents, think of all the parents that are out there. Think of all of you that are parents. The ability to save your children if you're myopic from what you have gone through, to know that you are doing the absolute best for your kids. This is huge for parents. For us, I like to constantly be reinventing the practice. And so bringing this on in the practice was, I want to stay up to date. I want to stay current. I can't just refract all day. I need to be learning something new, adding more services, adding more joy to the practice, doing as much as I can to help our patients. So there is a personal benefit to me and to us that we get to do by bringing this into our practice. So let's start about talking about having the conversation. The conversation sometimes can be some of the most daunting parts to this whole process. How do we bring it up? There's so much to talk about. Well, let's break it down and let's go through the different pieces. Whether we like it or not, we are salesmen, saleswomen. We are constantly selling our services, our skills, our abilities. And we always think of salespeople as, not great, honest people. But that's not true. Sales doesn't have to be an ugly thing. It can actually be a really good thing. Because if you think about what we're doing, we are figuring out what our patients' needs are, and we're finding them solutions. That's an awesome thing that we do. We're not selling them useless things that they don't need. We are selling them services that are going to make their life better. We are figuring out during our exams, what do they need and how can we make their life better? And that's really what it does. By proper communication, we really build trust and we build relationships with our patients. So some of the best tips that I can give you with respect to communication is always be straight up, be honest, be straightforward, be open with your fees. Don't hide any of that stuff. Don't ever give patients this ability to feel like there is anything going shady on, right? I'm always just very straightforward with what things cost, with how much time things are going to take, very genuine, very open, very honest, I'm just listening and I'm here to help. That's my goal. When patients know that your primary objective is to help them, that just fosters so much good relationships and so much trust with them that they'll keep coming back to you. I want you to be prepared for some of the common questions that people have, just really understanding what myopia is, understanding what my myopia control is. Why are we doing this? Why are there costs associated with this? One of the big questions that I got in the beginning when I used to talk about this was, how come we haven't heard about this yet? If this has been around for so long, why is this now still becoming a new topic of conversation? That was a tough one. Because people were upset. Why didn't I know about this 5 years ago when my child started to become myopic? I didn't know. I didn't know what I needed to do. As I'm learning, I'm teaching them. So being prepared for those questions is important. One of the things that I love to do is be super positive always. You know, when a parent comes in and their child needs glasses for the first time, you know, it's hard, it's emotional, and it's like parents take it as, gosh, I failed my child and I've given them this. But I spin it in such a powerful way that this is the best time. If you're going to be myopic, this is the best time, because when we were kids, we didn't have these options. We didn't have any choices to reduce our myopia, but there's so many things available now that we can help our kids, that this is the best time. And so just coming at this from a very positive perspective. I use marker boards, I use models. I really try and explain myopia so people get it. My simple definition is really understanding how the eye works. Light comes in through the front, it focuses somewhere inside the eye. If it focuses on the retina, you don't need glasses. If it focuses in front or behind the retina, you do need glasses. Myopia specifically is when those images focus in front of the retina. It's really easy for them to understand, and it's important that they get it because it helps with explanations that are going to come down the road. Explaining what the risks are. Yes, we can say the words glaucoma, retinal detachment, right? But what does that really mean? And thinking about the child who's hearing all of these conversations, I really like to use the dough analogy with respect to our retina. And I look at a child and I say, think about dough. And when you pull that dough and pizza dough and you stretch it and you stretch it and you stretch it and you keep pulling, what's going to eventually happen? And they say it tears or it rips or it makes a hole, and they get it. And then, you know, we can have the conversation of, as the eye elongates, the retina doesn't grow, it stretches. And that same thing that we are trying to prevent in their future is preventing that growth from happening so much so that retina becomes so thin that those holes actually develop. How does myopia progression happen? I really look at this diagram right here, right? And, you know, I may pick up a pen and I may draw this, and I'll say, you know, when you're looking at something, the image may have a curve, it may be perfectly straight at the back of the retina, but the back of the eye is curved. And why myopia progresses is because this curved part of the retina actually doesn't reach the image. So it tries to grow to reach the image. But as this whole thing grows, now your fovea is further out and we need a stronger prescription. So just to have an understanding of how is this all happening, we're going to come back to this diagram in a moment. Age of onset is something that we need to understand. And this graph here looks complex, but simply the younger the kids are when they start myopia, the greater the myopia is going to be. So if we look at this here and we look at this blue dot right here, so this is someone who's 8 years old and is starting with -1 myopia. By the time they're 17, they're almost a -650. Versus someone who's 15 that starts as a -1 is only at a 1.5 when they're 17, right? So the earlier that myopia onsets, the more myopia is going to set in. Okay, so what does this mean for us? It means we need to be getting our kids in early to be examined. I had a mom today who's having a beautiful girl in the next month. And, you know, one of the first things I said is we start checking kids at 6 months. And she was like, I had no idea. I'm going to put it in my calendar now that we need to bring her in for her 6 month and just start that early education, because I want to catch this stuff. Did I dive into myopia with her at that point? Nope. All I wanted is to plant the seed of 6 months in her mind so she knows that we need to start monitoring. So what's myopia control and what can we do? What's the goal of it? What's possible? This is now where we dive into this conversation, and I come back to this. So when you have this image that's focused on the back and you have this hyperopic defocus back here, well, what do we do with myopia control? We create a parabolic image that hugs the retina better so that the retina is going to want to cling to that image so that the retina has no desire to want to grow and expand. So optically, with all of the options that we're given, most of them except for atropine, this is what we are creating, is this parabolic shape on the retina. So the retina just wants to stay close and hug it and has no desire to keep growing and increasing that axial length. these images are simple, but they understand. And it helps me to answer questions when they say, I want to do ortho K and spectacle lenses, and I want to do this. And it's all the same mechanism of action. And when it's the same mechanism of action and you're doing 2 or 3 things, it doesn't make sense. You don't need to do all of them. If you have 2 in 2 different mechanism of actions, they are now adding to each other. But 2 of the same thing is not going to give you a greater impact. So what are our treatment categories? I break it down into 3: contact lenses, glasses, and drops at night. You guys don't have glasses in the US, and I'm so sorry for that. I am going to talk about spectacles and what we have available, but it's going to be a game changer for you when it actually does arrive in the US. It's huge. And I will say this, if you guys need anything with respect to your kids, please call me. I will be happy to help you to sort this out. If this is something that you need for your families, like, please reach out. But let's dive in and go into these 3 categories. Before we talk about myopes, let's back up a second. I get a lot of questions about emmetropes and hyperopes. What do we do about those? Do we just ignore those and really just start thinking about people when they're myopic? Carla Zadnik, Jeff Walleen from the Ohio State did some really great research that came out a few years ago about emmetropes and hyperopes at certain ages. When you see children at age 6, 7, 8, 9, and 10 that are mildly hyperopic, there is a very, very high likelihood that they are actually going to become myopic eventually in their future. So I actually start looking at this population and saying, hey, you're hyperopic now. I want us to be thinking about this and planting seeds early so that we may now be proactive and possibly think about early treatments, especially if their parents are very highly myopic, right? So if you have a child who's 8 years old, who's half a diopter hyperope, but their parents are a -4, they are going to be at high risk by the studies and by the genetics that they have with their parents. When we think about lifestyle changes, we're going to dive into each of these as well. There's outdoor time to be thinking about, there's diet, there's exercise, and there's computers and devices. They're everywhere in our life. So we got to be talking about all of those. Kate Gifford is a clinician out in Australia, and she put together this beautiful diagram that I really, really love. It's more for me to understand and for us to understand sort of this podium of where do things stand. And, you guys have access to all these slides, so you have this, but this is just a nice breakdown of what's more effective, what's least effective. Again, we're going to go through each one of these so you have a better understanding of all of them. But this is just a really nice image, because you're going to have these conversations with your patients of, well, what's the best treatment? And we're going to see, how do we offer that? Is one treatment better than the other? It's a tough question. And the answer is, yes, I can tell you that spectacle lenses have a certain percentage of reducing myopia. Multifocal contact lenses, atropine, have a certain, ortho K have a certain percentage of reduction that all the studies say. But those are based on bell curves, right? So someone had very little effectivity and someone had 90 to 100% effective. And then we say the average is around that 50%, that most treatments fall into that 50 to 60% efficacy rate of slowing the rate of progression of myopia. Where does the child fall? We don't have the technology to say your child right now is actually here in the bell curve, so this treatment is actually going to be the best for them. We don't know, it's hard. So when you are making those decisions, you can't be thinking about just those statistical numbers of this is 50%, this is 60%, this is 60, 70%, because that is so abstract when it comes to the individual child. That child may excel with ortho K and not with spectacles, but you don't know that. And there's no way of you having the calculations at this point to figure that out. When I think about AI and myopia management, I am hoping that we have these devices that are able to put in all the details, ethnicity and age and axial length and parents' history of refractive error and put all these data points together, and then to be able to say, here's a true representation of what your child is at risk, and here's what the best treatment should be. That's what I think is coming. I don't have anything to concrete say that, but that's where I feel like this is going to go with respect to AI. So how do you choose a treatment method? For me, it's about really figuring out what patients are going to be compliant with. To be honest, yes, I will factor in all of the things that I learn about them, but it ultimately comes down to is, what are you actually going to commit to, and what are you going to move forward with? Whether it's the parents that I have to manage or the child, it's about, as a team, they are a team, what will they actually commit to? Because this is not something that I want them to start for a couple of months and then give up on. This is years and years that I want them to be committed to, knowing that, yes, maybe after a couple of years, something's going to change. We're going to learn more, for sure. We're going to learn more. And maybe their minds are going to change and they're going to want to switch treatments. No problem. But this is what I want to make sure, is that I pick a treatment that they're going to stick to. And how I really do that, it's oftentimes bridging the gap between what the parents want and what the child wants. Involving the child in the conversation is so, so important. I treat them like a little adult, and I sit with them and I talk to them and I make sure they understand what we're talking about as much as they need to understand. And I involve them. If I'm drawing something, I bring both parents and children together so they can see what I'm drawing. I ask them if they have questions, and I ask them, what is it that you want? What's important to you? And, when they look at me and they say, I really want contacts, or I really want to stay with my glasses, that's really important for them to be able to vocalize and for the parents to hear. Because you have those parents that are going to come in and be like, absolutely, I want this, and this is what I've done my research on, and this is what and if the child is sitting there petrified, you're never going to get anywhere. And forcing that child to do something that they don't want to do, it's just going to create chaos in the home. So if you can manage that right from the get-go, that's really important. Okay, so you've explained all of that stuff up until this point, and now you're 30 minutes behind. Like, how do we do all of this, and how do we explain all of this? Because with every step of what we just talked about, your parents are going to have how many questions? Yes, but, and the questions are just going to keep snowballing. And I haven't even got into the nitty-gritty of the details of the treatments that are available with them, or studies or anything like that. Like, this conversation can go on forever, but this is where you bring your staff. So this was my staff a couple of years ago at a Halloween. So we do Halloween big, and this is them. And Sarah on the left here, she is my myopia management expert. She has helped me so much. And I have really, whether I call her my expert or my go-to or my myopia whisperer, she is the person that has helped me reduce this 30 minutes to far less. I have, in every aspect of the clinic with all our different specialties, every one of our staff is sort of leaned towards we really love this specialty for whatever connection they have to it. Our concussion clinic, we have one of our staff members that has had a past concussion. So she's so passionate about that she just wants to help all our patients in that department. Sarah has jumped on our myopia clinic as well as our contact lens clinic. And I teach these people that want to learn more about this. The more I teach them, the more they free me to be able to do what I do. And how this has worked is that I've given my patients really a person that they can lean on to ask questions to, that they don't have to come directly to me for. I've given them someone that they can say confidently, you get it, you understand, I'm going to ask you questions. I don't feel comfortable asking the doctors, or I ran out, or I forgot this question. They don't have to come back to me. They're not emailing me. They're not calling me. And I'm not the only one holding this information. The more I share with the team, the less work that I have to do. So what happens now is, in my clinic, I will bring up this concept of myopia management, and then I will share this with them. I'll bring over my staff member and say, hey, here's what we're talking about. Continue. And they will keep going, and they will answer the questions. They know what the process is. They know what the fees are. They know all of that. I don't need to have those conversations anymore because I've created it, but now I've handed it over to our staff to really take it over. Because we have so many services within our clinic, the way I look at my exam, and I'm lucky, I have 30 minutes with my patients, and I know not everyone gets to do that, but I have 30 minutes with them, and I see that as my discovery. I spend 30 minutes with them to really say, what can I learn about you? And what can I do to make your life better based on what I've learned? And then I will plot it all out for them, and I'll say, here's what we can do with this. Here's what we can do for glasses and contacts and dry eyes and aesthetics and this, and this. Or I can refer you to this part of the clinic where this doctor is doing this. And then I lay it all out, and they'll say, I have questions. No problem. But I take them out into the gallery and I call over my whisperers for all the different things that they need. And I say, Denosha, I need you to go over this, this, and this. And I explain to them, and I do the handoff with multiple people. And then I let them sit and close or do the rest of the conversations. It makes it so much easier because, like I said, I don't have to do all the work. Okay, we're going to take a pause here, and we have a polling question. Greg, I'm going to get your help here. And I'll read out this first question for us. What form of patient education is helpful with explaining myopia management? Informed consent document, myopia management brochures, a staff member who is your myopia management counselor, myopia risk calculators, or all of the above?
And Shalou, the only thing that has rolled in so far is how do you manage atropine? But I mentioned in the reply back that I saw your slides and you'll be coming up to that. So
100%. We're going to dive all into atropine and every one of those modalities of treatments into deeper conversations. You've got me for 2 hours. I got lots for you.
All right. Looks like everyone's replying here nicely. So I'm going to end the poll, share your results. And
yeah, so we've got a bit of a spread, and all of the above is absolutely correct. What's really nice is a lot of the brochures, informed consents, risk calculators, they're already out there. You don't have to create any of this stuff. It's already out there for you. And one of the best things about our profession is we are so giving with all the knowledge we have, with all the stuff we have. Like, people just share everything. It's all available online, and they will even give it to you and say, hey, here's the original format that you can just take my name off it and use it. One of the things that I like to do, so I'm in Toronto, as Greg mentioned, in Canada, and I'm a huge hockey fan. So I had to throw in the Leafs here just because I had to. But one of the things when we think about a game plan is I want you to be thinking bigger than just the immediate appointment. I want you to be thinking about a lifetime of treatments, and at minimum be thinking about a 2-year treatments. So whether you're fitting scleral lenses, whether you're doing myopia management, I want you to be thinking about, how do I describe this process to a patient with respect to what are the next 2 years going to look like? And however you've created the setup, I want you to outline that for your patients. So, my patients understand what the assessment's about, when we choose a modality, what that looks like and what that fitting process is like. When do I need to see them back? What are the charges and what's the expectation over the next 2 years? I need them to see that this isn't just a one and done visit, but I'm planning for continued care for many, many years. And at least I'm talking about 2 years, but this is going to keep going, because people will say, well, when do we stop this? Well, we don't. We never do stop myopia management. It keeps going. And we stop until somebody says, I really don't want to do this anymore. That's when they're stopped. I'm never going to stop it. Setting realistic expectations. Some of the things that we had mentioned in the beginning is really important about, again, not stopping, the importance of monitoring that, myopia, it's not linear at all. There's no real predicting of, because you had progression here, we're going to keep progressing. You could have a year of progression and then it flatlines for years and then it progresses again. We aren't actually stopping. We are slowing it down. So parents need to know that when they are committing to this process, things are still going to change. And that's really important. Things are still going to change. We are slowing it down. How much we're slowing down, there's no way for me to tell you. I can only tell you based on data that we are slowing things down by 50 to 60 to 70% based on all of the decades of research we have. But there's no way for me to right now say, your child is definitely going to be a -8, and I'm definitely going to get them to a -4, and that's going to be the max. There's no way to do that, right? Because we're never going to be able to say, this is where they are, and this is how we're going to bring them backwards. There are a lot of hesitations. When I would go through this process, I had parents that were just like, don't want to pay for this. I don't have the time for this. I need to think about this. There's so much research to do. This is all new stuff. I need to speak to an ophthalmologist, send me to a pediatric. Like, it was crazy the amount of hesitations that I had. And so I kept saying, no problem, no problem. Let's bring you back. And I would send out so much information to people. And I kept on losing people. I kept having so many people say, yeah, no. And I would lose them, whether it was the cost, the time, the lack of understanding. And I was just like, this isn't working. I get that I need to explain all this stuff, but I'm spending a lot of time. I've spent a lot of my staff time, and I'm not getting enough people committing to this. Committing to this is not just about me making money. This is about me knowing that this is the right thing for our patients. And how do I make sure that those patients actually get the treatment that they need so we do the best thing for them? And so I had to change. And I really did, because I feel like a lot of those conversations in the beginning, where I was talking about studies and research and sharing these long emails with all of the different options and going through all of this, it was kind of for me to convince myself that this was important. And once I actually was like, oh my God, this is so important that I just need everyone to do this. Like, I can't have you not say no to me. I started changing my conversations completely. And myopia management changed for me in the sense that it was no longer an option, but this is now standard of care for me. When I see a myope, when I see a pre-myope, I don't talk about, you can do regular glasses or you can do myopia management glasses. You can do regular contacts or myopia management contacts. It's just this is the only option, is myopia management contacts. Because my job is to give the best recommendation, to match those needs with the services that we're able to provide and give the best. And the best I know is doing a treatment of myopia management. The one thing for sure we know is myopia is going to progress. Doesn't matter when it starts, it's going to progress at some point. So I don't need to convince myself and watch for progression to happen to go, yep, it's progressing. Let me start treating now. I know it's going to progress. So I've actually simplified a lot of my conversations because I don't talk so much. I actually just give the recommendations, which are the best recommendations. And I'll show you the other ways where I have created more wins and I have fewer people dropping out, because every time you ask a patient for more money in this process, you're going to have people drop out. I want you to do an axial length measurement and it's going to cost you this much. Half are going to say no. Now, once you do that measurement, I want you to do a myopia management assessment. More people are going to say no. I'm going to have you charge you for this and this. You're going to keep, and by the end, how many people out of the 100 that you spoke to actually are moving forward? It was too little. So I'm going to show you how I changed my routine a little bit to maximize to the point where really every one of my myopes is in a myopia management strategy. And I know 100% because I have glasses, that is the game changer, where it has really made it easier for me to be able to put all of my patients in some form of a treatment, but you still have a lot even without the glasses. So let's dive into these a little bit more. There's a lot of studies about soft contact lenses that have happened over the last decade and a half. And when we collect all of this and we look at all this data, we see that these lenses are good. They're working. They have a 50% efficacy rate on average. They have an impact on refractive error and on making a difference on axial length. There are a whole bunch of different options available. And the one thing that we know is we need a centered distance design. So any type of custom contact lens that you can put a center distance in, that's a multifocal. You can actually use that lens for myopia management. It may be off-label, but everything we started with this years ago was off-label. When you look at what's available, we have Ability that's from J&J. That's available in Canada. You guys have MySight. Ability is going to be coming soon. You also have Natural View, and there's an iris lens that's coming. We have hybrids. We have sclerals. We can be using all of these types of lenses as long as they're a center distance lens, and you want at least a +2 to a +250 add power. Those are what the key factors that you're looking for. But, when we started doing this 12, 13 years ago, we didn't have a one-day disposable option available that was this good. And we have great products available now. This is a really cool paper poster that Giancarlo and Abe Vanderwerf did. And I just threw this in there because I wanted you to see globally what's happening. And this was at the Global Myopia Symposium. And what they did here was they were taking a look at the power profiles of soft multifocal lenses. And I just thought this was a really cool diagram where you could actually see the different add powers of the different types of myopia lenses here that's available. The other point about this is myopia is a global condition. And when we were running the Global Myopia Symposium, we had 84 countries in attendance on this virtual call, on these virtual meetings. Like that's crazy to think that the entire world is thinking and working on myopia management. No matter where you are in the world, work is being done on this. And it is such a crazy collaborative, awesome venture that we're all working on together. And I just find that really, really awesome. We talked about the mechanism of action for myopia management in general, that creating that myopic defocus, that parabolic shape on the retina to match the curve of the retina. That's how soft contact lenses work. By having the add power within the pupil, you create this parabolic shape. When we think about concerns that parents have, the same concerns that they have about contact lenses, it doesn't matter if we're talking about a single vision lens or a multifocal lens. It's about whether they're going to get them in, whether they're old enough, whether they're safe. All your regular explanations, those are the same conversations you have. When you have someone in single vision switching to a myopia management soft contact lens, it's easy. Kids are so flexible. It's very rare that you have them complain. And when you have these great products, it's just an easy swap over. All of the benefits of contact lenses, these are the same conversations you have with your parents. The only reason why things may not work is, a few years ago, when we had limited modalities and we had limited powers, then maybe you have to switch brands and move things around. Things are very comfortable these days. If things aren't comfortable, I tend to think more about dry eyes and thinking that there's something wrong with the ocular surface than just hopping around brands. And if you do put a lens on and the kids are complaining that it's blurry, I don't want you to be thinking about reducing the add power, because studies are saying that we need a 250 add in there to actually be effective. You want to just over minus them a little bit to balance out that blurriness that they're feeling. Don't feel bad about that. It's okay in this case because you have all this add power, but you need that plus 250 add power. So it's very rare that I have to actually switch brands, but I had a set of twins, and one twin liked the Ability lens and the other one liked the MySight lens from Cooper Vision. And, it was just what they preferred, but, we got them in those lenses. I've got another polling question here for you. And what does not help you determine your unique recommendations and treatment plan for your patients? So what's not helpful? Both parents and patients' motivation, the family's financial means, what you typically recommend for every myopic patient, the child's preference or treatment, the parent's time and availability. One of these things is just not helpful in making you make this decision of what recommendation you're going to make.
While we're waiting, Shalou, a question came in.
Mhm.
For kiddos, say 11 years old, they have both parents are -6 and above.
Yep.
Well, can we prevent this, or is it too genetic, so to speak?
No, you absolutely can. And so if that's the first time you're seeing that child, right away you put them in something. Whether they're a -50, -1, a -2, you start right away. And depending on what their power is, you might even do multiple things, right? You take a look at what data you have. Their parents are highly myopic. That's their risk factor. You look at their axial length and you see how long is their eye. When you have an eye that's longer than 26 millimeters, that's when the risk of future complications comes in. So we'll talk more about axial length, but axial length is really important to understand where are they in that shearing forces, where that retina is being pulled. And then are they a -50, a -1, a -2? Regardless, for me, I'm diving in and I'm starting treatment right away. Okay, so what you typically recommend for every myopic patient? Yes. So that's about being generic. You want to use all of the other pieces to help make your decision. And the piece that you don't want is doing the same thing for every single one. It's basically creating a unique treatment protocol for the individual patient based on what they're actually going to follow through. Ortho K is something that I have been doing since I was in school. For me, this is, the 3 buckets. You've got contact lenses, you have glasses, and you have medications, the atropine. So those are the 3 options that we look at. Ortho K, we all know what Ortho K is. To me, the key thing here that I want to tell you is that this is magical. When you're talking to your patients, you want to look at the child and say, these are your magical lenses. This is going to be awesome. You're going to put them on at night. And when you wake up in the morning, you're not going to need glasses or contacts. That's magic. What's really great about Ortho K is that the parents are fully in control because everything stays at home. And so when you have those parents that need to be hovering a little bit more and being more protective and want to have full control, this is a great option for them because everything stays at home. Nothing actually leaves the house. When we think about some of the benefits of Ortho K, when you think about those kids that are very active, that are maybe swimmers or that, are high into sports, soft multifocals are great, but this is also an additional option because of the fact that everything stays at home and you don't have to actually send the kids to school with anything. When it comes to safety, I just want you to see, because I mentioned that story about the original ophthalmologist here in town that were just all negative about Ortho K. There are so many studies that show how safe Ortho K is. And if you need this list, here's this list for you that you can then share with people to reinforce how safe it is. The one thing that's tough with Ortho K is that because we are changing the curvature of the cornea, we can't actually measure what the refractive power is. The only piece that we can actually measure is axial length. So we have good data on how Ortho K impacts axial length, but we have no way of gathering data on what the refractive error is. But when we talk about the efficacy of Ortho K, we're at that 50% number again too. Soft multifocals, Ortho K, and atropine all have 50% efficacy. How Ortho K lenses work, you have reverse geometry lenses, and the tear film creates this pressure gradient. You have this negative pull force on the periphery of the lens, and that's here where this return zone is, and you have a positive push force in the center. There is no pressure that's actually made with the contact lens on the cornea. It's all hydraulic forces. The fluid underneath the lens is pushing and redistributing tissue. So that's really important to know is you don't lose any tissue in this process. It's a redistribution from the center to the periphery, the mid-periphery. The efficacy of this and how this works, it's that same, creating that parabolic shape on the cornea. What's really important is when you have a pupil, the pupil size, you need to know how big that pupil is because the treatment zone has to be within the pupil, obviously, for them to see clearly, but that periphery that gets built up as you push the tissue out to the edge, and now you have this plus ring of tissue that's heaped up around the treatment zone, all of that needs to be within the pupil. If it's not within the pupil, you're not getting the effect of that plus power. And this is where the customization of Ortho-K lenses has really come to say, tell me what the pupil size is, because we're going to shrink the treatment zone to make sure we get that ring of plus power inside the pupil, so we can actually create that parabolic shape on the retina. Crazy advancements that's happened with Ortho-K. If you're not a fitter for Ortho-K, I want you to be thinking about who's around you, who can you refer to, create those co-management relationships. I have an axial length device, and every office around me that doesn't, I've said, we can share this. Send us your patients. We will do axial length for you, and we'll give you the data back. This is about how do we work together and collaborate. If you want to fit Ortho-K lenses, I think the best things that I can tell you is to pick one lab and work with them. Whichever lab you have a good relationship, whichever lab is close to you, whichever one that is easy to work with, and you do need a topographer, the most important maps on your topographer is your tangential maps. I'm happy to have a conversation with you more about topography and how to use your topography to look at this, but think about tangential maps are your true maps that really help you to see those bullseye patterns that we need to see with respect to Ortho-K lenses. When the lenses are sitting too high or too low, left or right, we need that topographer to really help us so we can troubleshoot. But stick with one lab. I use the same brand of lenses forever and ever and ever until I was like, okay, I'm actually wanting to experiment beyond what is capable. I want to be able to do more customization. Let me look for another lab partner that can add to it. Do I need 4 different Ortho-K lenses? No, I have 2. One, and how I have my 2, one is trial fit, where I have a big trial set that I use to do, because I'm in Canada, there's a lot of shipping that has to go back and forth. So I try and do a lot of fitting in office so that I reduce that time and reduce those costs. And then the other method is when I say, oh my God, this prescription is too high, or there's too much astigmatism, or I'm tired today and I don't want to do all this work. Let me be the tech for the lab, and I'm going to order everything empirically. I'm going to send you all the info and just send me a beautiful lens. So it kind of depends on which mood that I'm in, which method I want to go about. The third option, which is really cool, is we have these great profilometers and software and devices that will actually map everything for you and say, boop, here's the lens for you. You don't have to do any work. There's some crazy technology out there that has just made this so easy for us that it doesn't have to be the crazy, scary GP fitting that we had to do in school. It's just a lot easier than it's ever been. If you're a current fitter, keep going and, push your limits, try higher amounts of myopia, higher amounts of astigmatism. And, there's so much that we can do in that customization of that treatment zone and that pupil size. Like, that's the really cool piece when it comes to myopia management, working with your labs to be able to adjust those so you can maximize your treatment so that you're getting all of that add power within the pupil. Okay, atropine. I know there was questions on atropine, so let's dive in. The big thing when it comes to atropine, it's a pharmaceutical drug. Right now, this has to be compounded. This can be used solo. It can be used in combination. The big thing with atropine is, how do your parents feel about it? And it kind of depends on your demographics. I have some practices where they're like, we love atropine. This is what we use all the time. Our parents love it. They come in asking for it. And then you have other practices who are like, parents are like, absolutely not. No chemicals are going into my child's eyes. So it really kind of depends on your demographics and where you're at. But I think it's a very, very good tool to have in the toolbox. Lots and lots of studies have come out about atropine, and we are able to really look at the impact that it has on refractive error as well as axial length. Now, the older studies are saying that there isn't much of an impact on axial length. The newer studies are saying, no, there is a component to this. And this is about understanding really the mechanism of action. When it comes to concentration, The most recent studies have said that 0.05% is the most effective. When we started using atropine years ago, it was 0.1. That was a very high concentration that we were using, and we were having so many different side effects. And now the studies are saying 0.05. So where do you start? Do you start with 0.01, 0.02, 0.025, 0.05? These are all the variables that have concentrations that have been studied over the last decades in which is good, which is not. To me, you pick a point that you're comfortable with, whatever you are comfortable with, and then you go from there. If your patient is symptomatic, it's too high for the patient, lower the concentration. If the patient's not symptomatic and you see that they're progressing, go higher. There's no steadfast rule about how you do this. The studies are there to guide you. You really aren't doing anything wrong as long as you are communicating properly with your patients and finding out, how are you doing? How are we progressing? Are we progressing or not? And you go up or down this scale and you have options. In clinical trials right now, there are 3 drugs that are being tested to give us single-use manufactured medications. Why is this important? Because right now everything is compounded, and we have no clue how they compound it. It's their proprietary information. What buffering solution are they using? What preservative are they using? Are they using preservatives? What is their vehicle? What concentration did they use? How are they doing it? Are doing it the exact same time? Is it a different tech every time? Like, it's not consistent, and one lab to another is not consistent. So what this is going to do for us is it's going to bring consistency to help with our studies, but help with just knowing that our patients are getting the repeat same dosage every single time. I mentioned mechanism of action, and there are multiple theories of how this works, and one is that the choroid is actually thickened by atropine. So this is the one where all the other 3 are working on the parabolic shape, affecting the shape of the image and creating that parabolic shape that hugs the retina. This is the one that the mechanism of action is totally different. And is it causing a thickening of the choroid? Is it having a role on the cells releasing dopamine, and dopamine having a role in impacting and decreasing axial length? There's studies that are connecting those. And there's studies that are connecting sclerofibroblasts that are having an impact on the matrix of the sclera. So is this up and down regulation of the muscarinic receptors that are on the retina and on the sclera, is that being impacted in such a way that we're changing the matrix of the actual sclera and toughening it and stiffening it up so that elongation is not happening? This is all new stuff. We're just trying to figure out. And I think maybe it's a combination of these 3, but it works. And the efficacy of atropine is at that same 50% on average, like all of the others. The side effects of atropine, we know all of these things. So it's just about checking in with your patient, and how do we do that? Is this your first line of treatment? Is it your second line? Do you add it when something's not working? I have had patients where they were so young, so far into myopia that I said, I think we should actually try 2 treatments and start right away, because I don't want to wait 6 months for us to see that things got worse and then add atropine. That's not a common thought, but what's wrong with that? So there are a lot of people out there that are like, yeah, if we're very, very concerned, we're going to dive in with contact lenses and atropine. You will have parents that will come in and say, I want ortho-K, I want multifocal contacts, and I want atropine. And it's like, okay, let's think about mechanism of action. And we only need 2 of those there. In the first year, I want to bring them back every 3 months. But in that first stretch of 3 months, it's, if you're symptomatic, come back. Let's talk about it, because maybe I need to adjust. And I used to start with 0.02%, and then I moved up to 0.025%. Again, me feeling comfortable. And then I start with a 0.05%. And if they're symptomatic, I back down. I've been fairly successful. And over the years, there's only been 1 patient that was so symptomatic with even the 0.01% that we just had to stop it completely, because she would take it at night. And when she was going to school in the morning, it was too much for her, that she was still slightly dilated, that she just was not not happy with it. So there's only one that I've had that I just couldn't use atropine at all for. When do you stop using atropine? Again, we're all over the place. Some studies will say 2 years. Use it for 2 years and don't use it longer than that. Some will say, you know what, as long as you are monitoring properly and you're not having any negative side effects, go longer. There's a Cleaver team out of the Netherlands that says you can use it up until 15, but don't do it past 15 unless you're still progressing. And if you're still progressing, keep watching it, right? So like so many different things. We're learning, guys. We're still trying to figure out what's the right thing to do. And I think monitoring is the most important thing, and watching to make sure that our patients are okay. We're not doing any harm by doing this. Think about those symptoms, a little bit of burning, maybe a little bit of dilation. Okay, we cut back the concentration. Some people, when they do decide to stop, they will do it cold turkey. Others will say you have to do a taper. I've actually never done a taper when it comes to it. But there's no right or wrong answer here. These are things that we test and we experiment with, and we see what works best for you. All right, I've got another polling question for you. If you reduce myopia by 1 diopter, what reduction in risk do you reduce your patient from having in terms of future maculopathies? 10%, 28%, 40%, or 55%? This was again back in the very second slide, Dr. Mark Bullamore's research, why each diopter matters, the impact that we can have.
So we had a couple of questions come in the chat.
Please.
Do you treat patients in their 20s?
Yes. So there is no research out there right now that says in this category, this is effective or not effective. But we have a tool that could slow down myopia. And if someone is in their 20s and they're still progressing, or if they're in their 20s and they're scared of progress, why would you not? You have a tool that can do this. So I 100% do.
And what about toric or high SIL patients?
Yep. It's the myopia that we're looking at, right? So if someone is a high astigmat and not myopic, I watch, right? I'm going to treat them like I normally would an astigmat. But when you have a high amount of astigmatism, this is now where you kind of have to be creative, and maybe we don't have the contact lenses that we need. So we have to be creative either with custom lenses, or you put contacts and glasses together to make it work. It all depends on what your concern is from a future risk standpoint. 40% is the right answer here. That is correct.
Now, another question came in. If you're slowing the progression, but the myopic endpoints will be the same as a non-treated patient, how does that reduce the incidence of myopic pathology?
Okay, so you're looking at this as a whole. I'm looking at it as an individual patient. If I have turned a -8 into a -4, I have helped that patient, right? So at a -4, they're still going to be at risk, but they're not going to be at as much of a risk if they were a -7, -6, even a -5. And that's where even reducing them from a -5 to a -4 reduces their risk by 40%. Do we have any more questions?
You all caught up?
All right, let's dive into spectacles. So spectacles are so great, and I can't wait for you to have them, because when you have a child that's looking there terrified and says, I don't want to wear contacts, can I just keep my glasses? I can say, yes, you absolutely can. I'm going to go through the different designs that are we have in the past, but what's available now. And I'll go through it so you have an idea of what's coming. Single vision lenses, we've already talked about it. They don't help things. They make things worse. We know that under correction, the studies have been done that they actually make things worse too. So undercorrecting in the past was thought, oh, if I undercorrect and I make the eyes work, that this is going to help. Nope. Studies have showed that that's not good either. So you don't want to do that. Executive bifocals, They do help with reducing accommodative strain, reducing lag of accommodation, reducing accommodative esotropia. But from a myopia management perspective, over 3-year studies, they have a little bit of an impact in slowing down myopia progression. The problem is that 50% of near distance that you need to create that parabolic shape is just not happening with an executive bifocal. A traditional bifocal based on the COMET study is not doing anything at all with respect to slowing down myopia. So none of these 4 options are good at all. You're better off doing the other contact lens and atropine options. The first lens that came to Canada was in 2019. It's the DIMS lens. It's the Hoya lens. This Hoya and the Hong Kong Polytech University came and designed this. It's won tons of awards. This is the classic honeycomb shape pattern where in the lens, in that area of treatment, you have 50% of the zone dedicated to distance and 50% dedicated to near. You have a central 9mm clear zone, and then you have these honeycomb patterns of lenslets. There's 400 lenslets in this lens that have a plus 350 add. So no matter where the child is looking through the lens, they're getting a combination of distance prescription as well as that plus 350 add. So this is simultaneous vision. This is Eloise, one of my favorite pictures of one of my very first that I put in glasses. So I had to just share that with you. So this is kind of a zoomed in picture where you can see that when you look at this lens and you hold it up to the light, you can actually see that honeycomb pattern. You know, how you talk about this is important because, you know, when you look at this and patients are like, oh my God, what's all this scratches? No, look at how cool this design is. You have to use the right words to explain what you're looking at. With all of these lenses, we do have a limitation of amount of sil power that can go into this, you know, and with this, the amount of prism that can go in is a little bit limited. The one thing that I don't like about any of these lenses that we have, and we have 4 right now in Canada, is the fact that we don't have plus power. We talk about emmetropes, we talk about hyperopes. I can't put a hyperope into this lens yet, and that's where I'm trying to push these companies to say, come on, let's move past myopes and look at pre-myopes because we need to push them into that category. The lens properties, all of these lenses come with great coatings, with UV protection. They're just great products. Some studies with respect to the DIMS lens. So this lens has been on the market the longest out of all of them. And so I'm going to go through this just a little bit and just show you some of the data with respect to refractive error. The DIMS lens had half, like when we look at this, ultimately what we're looking at with respect to change in reduction in prescription, almost a 60% difference between the single vision group versus the DIMS group over a 2-year period, 60% reduction in axial length. You had almost 22% that had no progression at all in the DIMS category, that in 2 years, they just did not move at all. Like these are really strong, really great results. The 3-year data. So what happened in year 3? So you had these 2 groups. We had a group in DIMS and we had a group in single vision. All of the single vision got put into DIMS. So now you have 2 groups. You have the DIMS people that have been there for 3 years. And then you have the DIMS group that had 2 years of single vision and 1 year of being in the DIMS lens. So what we found is when you put people into the 2-year to the DIMS and you started, even though it was 2 years later, progression reduction started to happen. So what this taught us was it doesn't matter when you start, just start, because instantly when you start, you're going to start reducing the progression of myopia. So yes, it's better when you do it 3 years in advance, but when you do start, it's going to start happening. The 6-year data, well, this is now we have more groups. And in group, so we take the DIMS control group and now we divide those further. So we had 6 years of people in DIMS all together, and they showed the least amount of progression over 6 years, which makes sense because they've been in the DIMS lens the longest 6 years. The second group, so they stopped DIMS lens wear after 3.5 years. Okay, so They were in it from the beginning, and after 3.5 years, they stopped and went to single vision. So they had it for 3.5 years, and the remaining 2.5 years, they went down to single vision. So what happened in that group? What would you expect? You would expect that, okay, we're holding, and now you get rid of the treatment, and their progression started. As soon as they stopped wearing the DIMS lens, the progression started up again. So that tells us that the lenses only work when you're actually using them. That makes sense too, right? When we look at the control group, okay, so we had people that were wearing lenses for 2 years, and then they switched over in year 3, and they kept wearing them for 6 years. They continue to have reduction in progression of myopia for the remaining 4 years that they were wearing that lens. So this was start anytime because progression will start taking place. Then we had people that didn't wear them for 2 years. They wore them for 1.5 years. So they switched in year 3, they wore them for 1.5 years, and then they went back to single vision. So this is the group that had like the short end of the straw, because they only in the entire 6 years only had 1.5 years of the dim lens. What ended up happening is when they switched back, the progression started to happen immediately. And they had more progression than the group that had longer DIMS and then switched over to single vision, right? So basically what this is saying, group 4, is the longer you wear the treatment, the more treatment you're going to have, the better your outcomes are going to be. Once you stop, it's going to start progressing. Okay, second lens design that we have is by Essilor. It's called the Halt lens. This is it's a similar concept, but different. Again, we have this 50-50 ratio of add power to distance. There's a central distance, and there's like 1,000 different ringlets and dots, these lenslets all the way around, but these are in concentric rings. What's different between the first design is that each one of those lenslets in the DIMS lens were all a plus 350 add power. But with these guys, each ring has a different add power. So the closer ring has an add power, the next ring has a different one, and different. And we actually don't know what those add powers are. But what the purpose of that is to create actually a more appropriate parabolic shape that hugs that specific retina. So that proprietary design is based on what the distance prescription is, and they're trying to create a closer shaped parabola to match the shape of the retina. So it's like it creates more of a volume of defocus opposed to just one range of defocus, if all that makes sense. So what are the study data? What did they show us in the 1-year data? That they had a 60% reduction in progression of refractive error, a 28% reduction in axial length elongation, 100% clear vision. People did not complain about this lens, and 100% adaptation. I will concur that these are the 2 lenses that I've had in my office since 2019, and then these guys came out in 2021. I don't have complaints. In all those times, I've had one person complain, and it was because of my issue with the refraction. I just gave them too much SIL, and that was the issue. So I re-refracted them. But I don't have people complain and kids complain about there being an issue. The 2nd-year data showed highlights 67% reduction in progression. And when we now have 3-year data, so one of the things that Essilor did is they had this is a highly, aspheric lenslets, and they had a slightly aspheric lenslet. They had 2 different designs that they were comparing, and they found that the highly aspheric lenslets actually showed more myopic progressions. All the data is showing around that 50 to 60% reduction in slowing down the progression of myopia. Like, the results keep coming, and they keep showing great information. The thing is all of these studies are being done with both of these, are all being done overseas in China. And that's a really important piece to know with respect to the next lens design that's available. Okay, so just looking quickly at the availability here, it's again very similar in terms of what's available. We talked about the amount of SIL that's possible. The combined power between sphere and SIL in both of those 2 lenses is still a -10. But again, great coatings, UV protection. They're putting everything into these lenses to help protect our kids. The third lens design, this actually I don't have access to because they came very limited to Canada, to just a very few offices. And I actually said, this doesn't make sense for me based on their model, which was fine. It was years ago, but this is just a lens that I don't have very much experience with, but it's a very different design. This lens is, you can see here, and I'm going to show you, it's based on diffuse optics technology. Okay, so what does that mean? Is they have these microscopic scattering elements. So all of these, like, think of stippled dots out throughout the lens. And the purpose of that is to slow down and myopia by reducing the contrast. High contrast actually progresses myopia, and low contrast reduces myopia. So they took that concept and said, let's create a lens that actually reduces contrast on the retina. So if you look at this, I don't know if you can see that too well. You can see that stippling, those microscopic light scattering dots. And if you look at that lens, that this is one of my friends, my doctors, who took this image here, you can see this, right? One of the issues with this is people look at it and go, oh my goodness. But when the child puts it on, they don't have any issues and they don't see this pattern at all. Good clinical data that came out of this 2-year study, the results were actually so high that the question was, like, does the results actually make sense? What's different with these results is they said 40% had no progression at all when they use these lenses. And so the question that we say and we think about is, well, the other was only 21.5% had absolutely no progression in their 2-year study. Why is this 40%? This study was done in North America, where all of the other studies were done in China. So ethnicity could potentially play a role in this. So it's just sort of things to be thinking about with respect to when you look at these studies and what works, what not. For me, just having a glasses option, it didn't matter which one. I just need one. I just need one. So this is the newest one, the Zeiss Myocare portfolio of lenses. This was first launched in China and in Europe, and this just came this past year to Canada back in June. I am just starting to get my hands on it, so I don't have a whole lot of experience yet, but they've already sold over 1 million pairs of this. And they did about 10 years of research on this lens, where they tested 12 different prototypes. What this lens is designed is, you've got a center distance that's clear, and then you have these cylinders of plus powers. So their CARE technology is concentric, cylindrical annular refractive elements. So these concentric rings of add power. They have great coatings and UV protection, just like all of the other lenses. The front surface has those ringlets, and the back surface actually has freeform technology to help get rid of some of the glare and this distortion and really just improve the optics on this lens. What's unique about this lens is it's a portfolio. So they have 2 different lens options. One's the Myocare and the one's the Myocare S. What's different between those is the Myocare is for those under the age of 10, and it has a higher add power, plus 4.6 diopters of add power. So if you see here, you have a small center clear area, which is 7 millimeters, and you have more add power in this, whereas the Myocare S is for 10-year-old children and older, and we only have 3.8 diopters in add power. So when you look at these concentric rings, it's alternating between distance, near, distance, near, distance, near, right? So think of a concentric bifocal soft contact lens, same concept. With the older kids, we have a larger area. So when you compare these side to side, this is for the younger, this is the larger. You can see this graphic where they're showing you the larger center opening, less power in the S and more power in the original. So more power for the younger generations, because under the age of 10, that's where they're going to progress the fastest. Over the age of 10, they're not going to progress as quickly. So they've sort of factored that into their design. Their 12-month study, it's a longitudinal study, and they only have 1 year data so far that they have released. And this one sentence I've pulled out of the study, that the study demonstrates evidence of efficacy through an absolute reduction in myopia progression in line with the study expectations. Okay, so to me, this is, I need to understand more, because are you saying that you are completely halting myopia with this lens? I don't know. Is that what they're implying? I just need to see more. This is all new. And so I've put phone calls into my rep, and I'm waiting to find out more details, because I want to know more, and I'm excited to see what this lens design is saying. Some of the parameters and the difference between the Myocare and the Myocare S. So how have I put this into practice in my office? We have 6 doctors in the office. 5 out of the 6 are fairly on board with myopia management. Sometimes they forget about it. There's 2 of us that are like, every myope, this is standard of care, we are putting it in. What I've done with my opticians is I've said, I'm going to teach you everything. Actually, I didn't have to. All of the companies, when you go through these, they want you to learn the right way to use the products. So they actually put our staff through a training program. So they taught my staff everything. And now I rely on my staff. Remember, I have my discovery, I plant the seed, and then I take them out, and my opticians will do the rest of the work and say, this is the lens that Dr. Powell recommends, and this is how we move forward. But what's really interesting is if there's a myope that comes from one of the other clinics, from one of the other doctors that may have not thought about it, the opticians will actually talk to them about this myopia control lens. So if we are missing myopes within our exams, our opticians are now catching those residuals. Now, of course, I've actually spoken with all my doctors. My doctors are all on board that, yes, go ahead and speak to them. If I forget, you can easily do this. So everyone's, happy with this decision, and we're not stepping on any toes, but that's an additive way of how I'm capturing more of my myopes in this process and not missing any. How you fit the lenses, same measurements. You don't need anything extra fancy. We just do the exact same thing as we would do with any other lens that we're fitting. We want heights, we want PDs, we're taking a look at vertexes, and we're taking a look at pantoscopic angles, but not really, we're not needing to do all of that. I'm not so fussed with that. It's just your regular measurements and, just picking the appropriate frame. I think the key things when you are fitting these lenses is, if the frames are sliding down all the time, you've got to let the parents know that they need to be staying on the face and they need to be in the right position. So you've got to get frames that are adjustable so that, you can get them to be secure. The other key thing is you need a certain amount of hours of treatment to actually have a treatment. All of the studies that we've shown you, or I've shown you so far, are based on 12 hours of wear time. So if the kids are only wearing them for an hour or 2, they're not getting the right treatment. So that needs to be told to the parents. And just really understanding, I don't send them home with a list of, here are all the things that could go wrong or that your child could experience, and double, and this, and this, and this, and this, and this. I don't send them home with complications or things to look for. It's just, if there's a problem, you call us. And that's it. And we don't send them home. We show them, look at how cool your design is. Look at this. Look at the reflections. So that way we don't have someone going, what is this? So I'll give you a really good example. My cousin lives in California, and her younger son is myopic. And so we put him into an Essilor lens, and we sent it to him. We got all that done, and now we sent them over to him. And he took it to his regular optometrist because they needed an adjustment. And they were like, your lens is totally crazed, because they weren't used to this. And I didn't have that ability to sit with them in my office and show them design so that, so my cousin calls me and she goes, your lenses are defective. They're totally crazed and there's problems with them. And it's like, no. And we went through Zoom and we did all that, and I had to explain that. But that's something that we explain with our patients before they leave, so they don't look at them in the light and then say, hey, there's something wrong or scratched with the lenses. I always do happy calls. Happy calls are something that I started when I started the practice with respect to every pair of glasses that I dispense, every specialty lens that I dispense, everything I sell in the office. Not everything, but when it comes to glasses or contacts, any visual product, I will do a happy call on, which means in a couple of weeks, they will get a phone call and or an email to say, How are things going with your purchase? And I don't hesitate to make these calls, because if a patient is not successful, I want to know about it and I want to fix it, and I want to fix it during my warranty. If they're happy, great. You're so happy. Give us a Google review that you're happy, right? Because now I know that they're happy with that. If they're not happy, I want to really work on it. And I don't want them to be stuck with a product that they are just not happy with and maybe too shy to tell us that there's a problem. When you start doing this initially, you're just like, oh God, I'm asking for problems. I'm asking for people to tell me what they're not happy with, and then I'm going to have more work to do. You can look at it that way, or you can say, I'm taking this opportunity to really make sure that whatever I've sold, I am standing behind, and my job as your eye care provider is to make sure that I've given you a product that actually works for you. And if it doesn't work for you, we're going to make it right. And when you do that, people keep coming back. And, you know, we've heard tons of stories. Oh, this about the lens. And I'm like, you don't like your frame, right? I don't like my frame. Let's swap out the frame, right? It's usually that. It's usually sometimes just that simple. But when patients are like, but I've already had it for 3 weeks. I want you to be happy. You're spending this much money and you're not happy with your frame. Let's swap out your frame, right? And the same thing with these lenses. But I will tell you, with these myopia control lenses, I literally over the last 4 years have only had one person come back. And again, that was my error because of the refraction. All right, we've got another polling question. Your patient has been in 1-day multifocal lenses for 6 months and their prescription and axial length have increased at your last progress check. What is your next step? Stop wearing multifocal lenses and return to glasses. Myopia management is not working. Adjust the prescription and see back in 3 months. Adjust the prescription, see back in 3 months and add atropine to the routine. Adjust the prescription and see back in a year.
When I was in the at the European Academy of optometry and optics, I was like, did I miss these lenses? Like, I was walking around, it was a big deal, the vendors were there, and I'm like coming back like, nope, not allowed, not available. I shouldn't say not allowed, but not available yet. But that was my question: is this something that needs to be FDA cleared, or is this just something that the companies just have to release here, or is it a combination of both?
It's stuck in FDA. That's where it is right now. So it's just easier to get things approved in Canada, and that's why we have them all here. And it's just the hoops that have to go through, and all the testing and all the proving and all that. That's where they're stuck. So it's still looking, the last I heard was 2025, which is brutal.
So there are a couple of questions that came in. Do you charge upfront for all of the follow-up work?
Yeah, it's a really good question. Let's just talk about it right now in terms of fees. Actually, you know what? I'm going to save it because I have a couple of really good slides where I dive into how do I treat assessments versus my own patients and how I break it down, and we'll talk about it.
And what is the price difference between a standard single vision and a myopia control lens?
I think in our office, we are at almost double for a myopia management lens. So how do you do that, right? So the way we do anything and how we recommend, if you truly believe that the myopia management lens is the better product, that's your first recommendation. And if they say no, then you start working down, right? If you say, here's a regular lens and here's a myopia management lens, and this is half the price, and this is double the price. And now you're going through this game of trying to win them over and make them, all they've heard is this is double the price, right? So I don't do that. I kind of work backwards. It's kind of the same thing with insurance in our office. I don't come in and say, how much insurance do you have? And then try and work within their insurance. We don't talk about insurance till the end. And it's like, okay, here's what we have created for you as your best recommendations. Oh, your insurance is going to give you this much off. That's the bonus for you. But I don't work within what insurance companies tell me. And I know it's a bad example because insurance in Canada versus insurance in the US is totally different, and all of that is different, but it's just how you approach the conversation. Okay, so 2 big answers came through, which was adjust the prescription and see back in 3 months, adjust the prescription in 3 months, and add atropine. Both of those are really great answers, and neither one is wrong. I think you take a look and you make a decision on what you feel comfortable with, what the family feels comfortable with, and you make your best clinical judgment, and either one of those, right? Let me give you more specifics. If the axial length was 24 millimeters and it changed to 24.1, I would probably go with the see back in 3 months. If we were at 25.6 and we moved to 25.7, that's closer to 26. And 26, once you hit 26, your risk now increases by 25% of future complications. I'm going to be more aggressive then, because that's my justification of why I want to be more aggressive. We're going to be diving into axial length soon, and we'll go into there. Low level laser light therapy. So I put this in here because this is the new buzz in the world of myopia management of, is this good? Is this not? It's so controversial. Laser light, low level light therapy is being used in concussion rehab, TBI. It's being used in dry eye treatments. It's being used in so many different areas of healthcare. But with respect to myopia management, it's controversial because we are putting light right into the eyes, and there's not a lot of studies out there. Are we using light? Or are we using lasers? Like, what happens when we had those laser pointers before? It was like, oh my God, don't point it in your eyes. And now we're saying, yep, point that red laser into your eye for 3 to 5 minutes, 4 or 5 times a day. Like, we're doing the opposite of what we've been told. And the two really controversial things that have come out with respect to light therapy is there was a paper that came out that said, these are both coming out from China. There was a paper that said, low-level red light therapy is amazing, and there has been absolutely no side effects. And here are all the papers and all the patients that went through, and nobody had any issues. And then there was a case report where a family spoke up and said, yeah, no, I followed these instructions, and we had our child in treatment for 5 months, and we did 3 minutes for 4 times a day, right? Just followed the proper protocols that were done in the study. And they went from 20/20 vision to 20/30 vision, and they had damage to their macula. And once they stopped treatment, 3 months later, their vision returned to 20/25, but they spoke out about it. And you look at this and you're like, yeah, but that's one case report, and there's all of this positive data. So if any of you know Maria Liu, Dr. Maria Liu, she's a practitioner from China. And we asked her, what are your thoughts on this? And she's like, oh my God, please, this is so controversial, because what happens right now is anytime there is a negative case report, it's hushed and it's not told about. So I guess the only thing to really say is that we have so much more to learn with respect to red light therapy, with respect to shining this into our eyes. And we just need to be careful. You know, what are the standards? What are the safety protocols? Eyes opened, eye closed, how many minutes, light versus laser. So just really, really be careful if you're going to dive into this, and just really do your homework and just be very cautious with this whole area. I think it's going to be an area that we're going to study a lot more, and you're going to see a lot more than this one paper here that's on this case report versus this one study that we have sort of combating each other right now, because it's really creating a lot of controversy in the space of what's the right answer. And the right answers, we don't know yet. Okay, with respect to diet and outdoor time and exercise, outdoor time delays the onset. So if you are emmetropic or hyperopic, being outside for up to 2 hours a day cumulatively, so 20 minutes here, 30 minutes here, all the way up to 2 hours, is beneficial to prevent the onset of myopia. Once you have myopia, it doesn't help it slow down. Okay. And that's where the confusion is with outdoor time. It's like, oh, you're myopic, go outside. Yes, it's good to be outside, but not because it's going to help slow the progression. Lots of things coming out on food and correlations between the progression of myopia and certain vitamins, and the link between diabetes and myopia, and what's right and what's wrong. I think we're going to start to hear a lot more about the impacts of food and how that impacts everything. You know, my culture, we come from a culture where your stomach is your engine for how your body performs. What you put in is how your body functions. So that's sort of been grilled in my mind since I was a child. And it's something that's slowly starting to come into our world a lot more. We know we think about foods with respect to macular degeneration and dry eyes. I think it's really important that we talk about foods with our patients and really learning a bit more about it. I have a lot of extensive conversations about food with my patients. Exercise, I think this is a great opportunity to talk about exercise, and a great time to say exercise is great. Okay, how do we track things? We have refractive error, and we also have axial length. I'm jumping a little bit because I want to make sure we cover enough about axial length because it's a really important topic. When I brought in axial length, I brought it in years ago in the form of an ultrasound. And the ultrasound was, you know, handheld, you needed anesthetic, it was operator dependent. Kids did not like it, but I brought it on because it was inexpensive and I needed to prove to myself again that I was actually going to use this data to help me make decisions. And once I said, yep, it actually is helping me make decisions, I then brought on an axial length interferometer that actually measures axial length with a proper device that's just like an autorefractor. It stores the data internally. It gives me graphs. It does comparables. It was 5 times the price of the ultrasound device, but for me, because it was worth it, I brought it in. The key number, I've mentioned it over and over again, is 26 millimeters. When you look at this graph here, your risk of future complications is less than 4% when you're under 26 millimeters. But when you go above 26 millimeters, that's when it starts to get really high. And that's where your risk increases. So keeping that 26 millimeters in your mind, that's your benchmark of you want to stay away from. After 30, that risk goes up 90, right? So everything above 26, now you're going higher and higher. Some important key metrics to look at, because these numbers, I think we always think about what are the normative data, what are the pieces that we're looking for, how much progression is okay, how much is not okay. So this slide I think is really important to sort of keep it on my desktop as a reminder. Emmetropic eye is 23 millimeters. If you have an emmetrope that has a much longer eye than 23 millimeters, you need to be thinking of, okay, we've got to be thinking about watching you and making sure that you're not getting closer to that. If they're a young child that's 8, 9, 10 in emmetropic, maybe you start thinking about atropine because they're a 25 millimeter. An emmetrope shouldn't be 25 millimeters. They should be 23. So that gives you this clue that something's myopia is around the corner. Emmetropes, so we use the benchmark of 10 years. Under 10, kids progress much quicker based on one of that earlier slides I showed you. Older than 10, they progress much slower. So under 10, an emmetropic eye is still going to progress 0.1 to 0.2 millimeters. Over 10, it's going to be 0.1. So when we think about a myope, those numbers are doubled, okay? More than 0.2 millimeters when we talk about myopic rates. Under 10, it's 0.3 millimeters of change per year. With after 10 years old, it's 0.2 millimeters of change. Okay, so why are these numbers important? Because when you're doing treatments, we know that we cannot halt anything. So if you are progressing less than these numbers, you're doing a good thing. If you are progressing at these numbers or higher, your treatment isn't working, right? So that's where these numbers come into play to kind of give you some idea of, okay, what amount is too much or not enough? When should I add or change or do something different? And these give you those benchmarks. Seasonal changes. In the winter, you are going to have greater shifts in axial length than in the summertime. And kids have growth spurts. Guys have growth spurts at around 14, girls have growth spurts around 12, and growth spurts are going to cause increases in axial length. When you have a data point and you do an axial length measurement, what do you do with that piece of data? So Dr. Langis-Michaud said with one data point, we can use these calculations right here and give an estimate of, based on their age, what their axial length should be. And you do the calculation and then you see what the axial length is. And if you're close, great. But if you're much higher, you know that, hey, we're off. Or you simply look and say, am I close to 26 or not, right? When you have multiple data points, then you can start looking at graphs and charts, and you can look at these progression charts. Around the world, people are creating these progression charts, and there's so many out there where you can look and see, I've got multiple points. Am I progressing with these relative norms based on these percentile charts? Am I growing at the right rate, or am I off compared to the norms? And then you can use these multiple data points. So lots of growth charts available based on age and sex and different ethnicities that are available for you to look at. And there's a lot of really great links out there that will teach you how do I use these graphs, right? There's a graphing app, Dr. Thomas Aller put this together. It's Myopia Care, where if you don't have, let's say you are doing ultrasound and you're getting your data points and you don't have a device that's spitting out these beautiful graphs, you can use this app to actually create your own graph and plot and see, and this will give you information as well so that you can graph it. So what do I think about and how do I use axial length? Okay, so we're kind of getting into the question or into that area of costs a little bit. I do myopia or axial length measurements on all of my kids under 19. I have the device. I wanted to gather data, so every child gets it done. My staff are awesome. They don't give me a hard time. I put in a new instrument. They understand why I'm doing it, and they just do it on everyone. They don't need to figure out if they're a myope, ametrope, or hyperope. I'm not asking the parent to pay more. I just do it on everybody. What it does for me, it gives me data to say, I need to have a conversation with you or I don't. And it helps me to move and avoid that loss of thoughts or loss of patients saying yes. So when am I suspicious? Whenever I see a myope, someone who's under 10, those low hyperopes or emetropes under 10, I think about growth spurts and seasons. I think about emetropes that are higher than 23. I think about myopes that are closer to 26, kids of high myopic parents, and anyone that's above the expected norms. These are when my red flags and bells go off and say, hey, pay attention to what we're looking at with respect to these patients. Okay, we talked a little bit about this. When you see change above those normative data points, then I get more concerned. Obviously, in the very first year of treatment, everybody wants to see no progression. That's what we aim for. But that doesn't always happen. So I need to have those benchmarks. And that's what that slide was, is what are my benchmarks to make sure that I am staying within, and again, setting those realistic expectations with my parents so they don't expect zero change all the time. When do you start? What's defined as a myope? For me, 0.25 is a myope, 0.5 is a myope. Whenever I see it, I'm not waiting to see progression, because just because you have 1 year of progression doesn't give you any indication of what's going to happen next year or the year after or the year after that. So I take in all of their risk factors, I take in their age, I look at their parents, and I start treating. I give my best recommendation. When do we make a change? Again, looking at the data that you collect. Is the refractive error changing? Is the axial length changing? We know myopia progresses. Can I do more to slow it down? If you're doing ortho-K and you're doing 0.1% atropine, can you do more? Or 0.01, sorry, not 0.1. If you're doing 0.01, can you do more? Maybe increase that concentration. There will come to a point where it's like, okay, this is the most that I can do, and we're still changing, but we're doing something, because if we weren't doing it, it would still actually be changing more. When do we stop? You know, what I think about is, when do LASIK surgeons say, you can go ahead and have LASIK surgery? Well, that kind of depends on the surgeon, but usually around 24, 25. And we know that myopes can still progress even up to the age of 24 and older. So it goes back to that question we had, would you treat someone who's 20? Yes. So I don't actually put an endpoint. I don't even talk about it unless a parent brings it up and says, well, how long do we do this? Indefinitely, until there's a reason for us to stop. Otherwise, there is no reason to stop. Really cool studies that came through during COVID is that being at home had an impact, and all of the device use that we had such an impact on increasing myopia, things that we already knew. We know that we need to cut down screen time and have conversations of how do we reduce this? How do you reduce this is by having people sit on the couch and watch TV instead of watching a movie on their cell phone. Try and push people to TVs instead of digital devices. Really cool study about education. The more education people had, the higher the amount of myopia was. And that's correlated to the amount of screen time and the amount of book reading and up close work that they're doing. Okay, last polling question, and then we're going to dive into that question about numbers, and then I promise I'm going to stop. So last polling question, what percentage of the world's population is expected to be myopic by the year 2050?
And then I have a question here that rolled in kind of privately to me here. It says, what if you don't have an instrument to measure axial length? Can you assume that if the patient has a steeper case, that they do not have a longer axial length compared to those with a flatter case?
It's actually a really good question. I don't think I've ever looked at the correlation between Ks and axial length, but it's now on my list to look into. To answer the question, you don't need axial length to do myopia management. You don't need it. It's an additional tool that if you feel is helpful, then great, bring it in. The reason why I brought in that first device was because I had Asian moms coming to me and say, do you have axial length? Because they had read about it and they knew that that was important. So I was like, I'm having my patients ask, I have to bring it in. And that was my trigger for bringing it in and then learning more about it. 50% is the correct answer. I do want to talk about, so this is the question on whether you need equipment or not. And it really depends. Start by just looking at your myopes and offering them options. Be prepared. Frequency of visits, every 3 months is what I like to do in the first year, and then every 6 months after that. Talking about fees. So remember, I like to plan for 2 years. Bigger than getting a fee, for me, what's important is that a child is put in a treatment plan. So how I do it is I have 2 different categories. I have the patients that are referred to me. They go through a myopia management assessment. I know nothing about them. So I have to learn. I have to do lots of tests. That's where my myopia management assessment fee comes from. And then I will charge them for the services that they are prescribing for. So if it's atropine, if it's soft contact lenses, if it's glasses, if it is ortho-K, they are going to pay for that service. Those services have different timelines. If you're fitting a soft lens, there's going to be a soft lens fitting fee, and there's going to be the follow-ups that entail that. And then there's going to be that management fee. So again, this is looking at the motivation. What is my personal motivation? What do I want? I want that child to be in that soft contact lens. So if I get them into the soft contact lens and the mom says, I'm not coming back every 3 months. I'm not coming back every 6 months. I'm not going to say, then I'm not going to put you in that soft multifocal. I'm going to say, okay, then here's what could potentially happen. And I'm going to see you back next year. And every year there is a myopia management fee that I charge annually. Okay. Now, if someone is absolutely dead set against it and there's like, you know what, we're going to buy the glasses, but I'm not going to pay your annual fee. Okay. I'm okay with that because they're in the glasses. I know that I'm doing something that is better than them not doing it. So for me, what I have learned is I started with these huge fees. And again, nobody was saying yes, or very few people were, or very affluent families were saying yes. And for me, I said, what do I want? Do I want those few that are going to say yes, and I'm going to get these higher fees? Or do I want more in the treatment and get what I'm getting paid for what I'm actually doing? You will have some parents that are like, I want to come every 3 months. I know you said 6, but I want every 3. Great. This is what I'm going to charge you for that. So for me, it's about tailoring it to what the individual family needs and wants. And for me, my goal is to maximize getting people into treatments and making sure they get the products. So I've done it in such a way that I'm good about it. Right now, think about that 6-month appointment. What am I doing? Do I need to do a refraction every single time? Maybe, maybe not. Am I going to change ortho-K lenses? I don't know. So maybe it's just coming in and doing an axial length quick measurement, and I look at it and going, hey, you're stable, you're good, out the door, right? So as you do more of it and you start to see, I promise you your plans and your change are going to change, because my fees changed dramatically. I was so high in the beginning thinking this is so novel, this is so, and then I was like, well, no one's doing this. So I had to change.
Perfect. I'm going to share my screen here now.
Perfect.
And then as I'm sharing my screen here, there was a question that came in, is what is your oldest patient in myopia management?
24 right now. She is a ortho-K patient that's been with me forever. I actually just saw her 2 days ago, and she said to me, she goes, I think I'm ready to come out of this, but I'm really glad that I did this, because my really good friend 6 years ago when I started, we were both similar. She didn't, and she's a super high myope now, and I'm not, because of this.
Perfect. I knew this was a huge subject and it'd be tough to do within an hour and 40 minutes, but Shalu, you did a great job doing it. I'm sure that there's more that you'd love to cover, but thank you for doing this for us. This is myopia management in clinical practice. This was a synchronous virtual course. Thanks, everyone.
Thank you so much.